Thank you. Sorry I can't be there in person. It was my fifth or child's fifth birthday, so I had to be at their fireworks party tonight. But been great to hear some of the talks so far. So thanks for the invitation. So I'm going to do a different sort of talk to what we've had so far. So this is more on the clinical side, so how we can get some of the great algorithms that have been developed so far into the clinic. So I'm going to talk about some of our experience in Oxford of a couple of algorithms we've tested in collaboration with GE Healthcare, but one of them especially is obviously of relevance to here because it's linking to MAP. So as you know, kind of PET image reconstruction has kind of evolved over the years. We had kind of filter back OSIM in the past, then with point spread function modeling. And then recently there's been kind of data-driven gating that's been used in the clinic with different manufacturers. We've also had MAP being used by GE. And there's been a wealth of companies looking at how to use kind of AI for an image enhancement, either GE with kind of PDL United with their kind of hyper algorithm and Siemens with fast PET. And also hopefully in future there'll be your work as well. So the map algorithm I'm going to mention, kind of the testing we did for implementation, is the GE1, and they marketed this as QClear. It's kind of the BSREM that we've mentioned up to now. And the way that they did this was they had one variable, in this case beta, to give the users kind of one parameter alter in terms of image optimization. And that was kind of varied depending on which tracer you might want to look at. The way they've implemented this sort of QClear style algorithm on their SPECT imaging for GE, they've actually got more than one parameter you can alter, but for the PET version, it's only got the beta. So when this kind of came out, we want to look at what the clinical impact was on our images. So the first patient we sent off to GE to kind of look at it was this 62-year-old male, an FTG scan. So on the left-hand side here, look at my pointer up. Here we are. You can see here we have the normal OSIM image, and this side here we've got the map image. So this is the first one we sent over, so we thought, oh, great, the lesion here has become nice, a little more conspicuous. That's a good sign. That's what you want to see when we look at these sort of images clinically. But we thought the skin uptake here on the BSREM image looked a bit hotter. So we thought, oh, has something gone wrong with attenuation correction? Because obviously for non-attenuation corrected image, you get this kind of hot skin effect. So, or has something happened here with our reconstruction? So then we decided we sent off a choline scan. So this tracer here, again, you've got the OSIM image on the left, the QClear on the right. So again, the lesion's much hotter, which is good, but we didn't get this skin artifact that we saw before. So therefore, we kind of concluded what we're seeing here is real kind of dermal uptake in the skin. And because the kind of map algorithm is working that much better, you're starting to see that kind of true dermal uptake in the skin that you weren't used to before. So it kind of shows you that when you introduce these new algorithms, people have to relearn what they're looking to see. And we'll kind of come back to that theme a few more times, really. So then kind of being a physicist with my kind of physics hat on, we wanted to test this with a phantom as well. So this is kind of my physics MP hat on. So use the NEMA IQ phantoms, the kind of standard phantom we've already mentioned so far. And this had 4 hot spheres, 2 cold ones. Here you can see the OSIM image. Here you can see the map algorithm. So you can see much smoother background, much better defined spheres. So therefore this is clearly better. Then we looked at the quantitative impact. So as I said, there's one factor beta that gets changed. So we change it from a beta of 100 through to a beta of 1,000. So you can see as you increase the beta, you decrease the noise in the image. So you decrease the background variability, but also you're going to decrease the quantitative recovery. So use this kind of phantom scan to use kind of a subset of these betas to then look at further with our radiologist. So then we gave the radiologist, set of radiologists different images all blinded from a beta of 200, 300, 400, 500. So the range at which we could see there's a kind of a quantitative improvement on the OSIM images from the phantom scans, but we wanted to see what the clinicians thought as well. So we did a whole range of different tumor types, different scorers, and kind of overall, the beta they preferred was this beta 400. So that's what we kind of recommended. We then went for FCG scanning. But that was obviously just taking kind of a sample of a few different patient sets, but we wanted to kind of test this in a range of different clinical indications to kind of prove its worth across different clinical situations. So in Oxford, we're quite lucky. We've got basically a library of old sonograms and list data. So we routinely store all our sonograms for all our clinical scannings. So I'll have sort of several thousand each year on each scanner. And we also have, for most of those patients, also list data. So people interested in collaborating do have a chat later on, drop me an email about that side of it. But in this case, obviously, we're looking at image reconstruction. So we just need the sonograms. So we kind of teamed up with our radiologists to kind of start to look through some of these old scans and reprocess them with this new algorithm to kind of test out. And principally, that was in order to kind of give confidence to this new algorithm before we started using it. So the way we selected our cases, well, we did a range of different kind of histologically proven cancer types. So this is kind of a lung cancer we've kind of taken out to kind of prove it's definitely cancerous. And then all the radiologists were always blinded to whatever the reconstruction was, so make it a fair comparison. So we did a variety of different investigations of this. This is our paper on pulmonary nodules. So here you can see this kind of pulmonary nodule, you can see SU max is 2.1. When you do the MAP algorithm, it goes up to 4.6. So it's far more conspicuous. And this was kind of 11 millimeter left upper lobe adenocarcinoma. But also with lung cancers, one of the thresholds that's used for lots of this is an SU max of 2.5. So if you use that as your kind of your deciding point for your kind of clinical significance, it's gone from kind of being below 2.5 to over 2.5. But this kind of brings me to the point of when you introduce new algorithms, people have to alter the thresholds that they're used to using. So clearly, if you're doing an improved image reconstruction technique, you've got improved point spread function modeling, improved everything else, your SU maxes are going to increase because you're getting closer to the truth. So people, especially clinicians, have to adapt the thresholds that they use and how these algorithms can be then implemented. But essentially, this kind of paper, we kind of looked at all the different cases and showed for these 121 nodules, we're getting kind of a significant increase in signal to noise, signal to background. So it makes it kind of an easier read for the clinician. And we're getting a more accurate report because we're getting closer to the truth of what we know is in that patient. There's another case is liver metastases. So obviously liver mets is kind of clinically really important to detect in patients. So if your patient has liver met, that's going to change their patient management. So it's quite essential to get that right. And if we can detect it early, that's clearly better for the patient. So here on the OSA image, you can see there's a clear lesion here. And then these two here, you probably might not call, they're very, very subtle. But on the MAP algorithm, again, that one's obviously still clear. And these two are just that little bit more conspicuous. Hopefully it displays all right on your screen in the conference hall. But you'll have to check whether these two are displaying that bit better for this MAP algorithm. So you can imagine if you didn't have this lesion in this patient and just had these two, using the newer reconstruction, you're more likely to spot these things early, and that's clearly going to be a significant benefit for that patient. Another area we want to look at was patient weight. So obviously patient weight significantly impacts image quality in PET, as I'm sure you guys know, and a whole load of different sort of dosing regimes and bed times have been kind of investigated to try and improve this in PET. So in Oxford, typically we do a weight-based approach. We've done that since we started PET, up to a certain threshold, and above that we kind of increase the time per bed. But still, with OSM imaging, as you can see from these images here, you get fairly poor image quality, especially for these obese patients. This is 184 kilogram male. So you can see the liver is very noisy. You wouldn't easily be able to detect a liver met in that. We then look at the kind of MAP algorithm. You can see it's a much smoother liver. You're more likely to be able to spot things in that than you were before. So we did this in a variety of different kind of clinical indications, and others have also done this too. Kind of following on like a whole range of different tumor types. So we looked at kind of pulmonary nodules, liver metastases, mediastinal lymph nodes, looked at patient weight, and also different traces. So as has been mentioned about zirconium, obviously with the zirconium, it's a very, very noisy imaging, similar to yttrium-90, it's very noisy images, so you need quite a different beta. So whereas these ones, we kind of use a kind of beta 400, and for these sort of algorithms, for visualization, we kind of use a beta of 4,000, so much higher. And for quantification, we use a beta of 1,000 where we're doing dosimetry on the yttrium-90. So there's different ways you want to optimize it depending on the tracer. And a whole lot of others done kind of research in this kind of area and showed the benefit of using these MAP algorithms, really. But the key thing that kind of helped the kind of implementation is this kind of combination of phantom and clinical work. So as I said, we got a variety of this sort of data out of the literature. We did different presentations, both at kind of conferences, national, international ones, and different kind of user groups, in this case G, because it's a G algorithm. But I think it really was helpful having this phantom and clinical scoring, because crucially then you've got the phantom evidence to kind of keep your physicists in the hospital happy, and the clinical evidence and the radiologists to keep the medics happy. So all this kind of helped to build diagnostic confidence. And we did the same sort of approach when we kind of implemented and tested out data-driven gating. So this is work Chris has obviously involved quite heavily in the past for. So this is another algorithm from GE where we looked at a cohort of about 150 patients, retrospectively went back and looked at the data-driven gating, which is kind of a deviceless approach, and also using the RPM variant gate, we put it on the patient's chest and the patient breathes up and down. But there's some issues with how that works when you use the device approach. So you look back and look at these scans, you can kind of see here nicely a case where can't really see the lesion clearly on this one, but much more conspicuous on the data-driven gating. So that was in the kind of patient side of it. And again, we had a clinician blind score all of those scans to prove that the benefit of DGG. And again, in this case, we use another phantom. However, here, unlike the image quality phantom, this was actually a kind of a 3D printed anthropomorphic phantom. This was actually a physicist's liver. So we did an MRI of a physicist, then printed their phantom. This was actually used for CERT, sort of Y90 optimization, but we also applied it here for F18. So see the sort of images we get, so it's kind of more human-like, so you're able to then see kind of lesions or necrotic lesions with a cold central spot and see the impact of this algorithm. And again, it helps having this kind of phantom and clinical view of things in order to get these things implemented over to the clinic and persuade people the value of this technology. So however, with any kind of new technology, as I kind of mentioned with this kind of the lung thresholds, people do need to relearn, I think. And especially with MAP, there's been a perceived issue with lymphoma, and similar with kind of PSF as well, modeling. There's a perceived issue that particularly with lymphoma, this matters. And that's principally because in lymphoma, the way it's done is it's all kind of something called the Deauville criteria. So it's a set of kind of criteria that have been agreed upon kind of by a consensus meeting. And it's based on reference liver regions. So obviously, if you can increase in your kind of SU max of your lesions, the ratio kind of between that and kind of background liver is going to change significantly when you bring in new algorithms. So if people use the kind of thresholds as they were on old technology, obviously they aren't going to necessarily be valid with new technology where your lesion SU max is going up much higher. So there was kind of a letter edited in the past saying people need to take care of it. We then did another letter back saying people should embrace progress, and because the benefit of being able to see these small lesions early kind of outweighs any potential to difference between the kind of Deauville criteria thresholds. And there's kind of work on going to harmonize that, and I'll come back to it later. But other than that, lymphoma in kind of PSF modeling or MAP, most other kind of trials and things are able to use kind of this new MAP algorithm and use it kind of in clinical studies. Although so far, kind of unfortunately, really, no one else really using MAP. It's just GE. However, we are getting quite a range using kind of AI enhancement. So, or to kind of comment a bit on how we kind of can implement and trust the AI enhancements in kind of in PET-CT within clinical practice, because again, it's slightly different to how we do kind of the DGG kind of MAP algorithms. So I'll talk about GE's Precision DL. So this is their kind of AI enhancement algorithm that they've used on their product now. So essentially, I think it uses basically a Q-clear image, a map image with non-time flight. You apply the PDL, and it basically makes the image more time of flight like. So therefore, it gives you them improved quantification, improved lesion detectability. And the way that they've implemented it is 3 different strengths, depending on kind of the user preference. So kind of similar to beta really. So you've got a high noise input. In that case, you want kind of a low level of image harms, the low level of PDL. If you've got a low noise input, then you could do a high level of PDL, kind of high level of image enhancement. So that's where, again, you want to think through what your image acquisitions are and think what enhancement you want to use with that. Because you would, if you've got a really noisy input, you want to over enhance that. You need to take care with choosing the kind of strength of enhancement you do, and that would apply for any of the different AI enhancements that are out there. So I think in order to kind of trust and use any of these algorithms, you need to know how they're developed really. So this one was developed with kind of hundreds of paired FCG images. So on the same scanner, they're reconstructed twice, once with a non-time flight map, and then again with time flight map. So the UNet could then learn the difference between non-time flight and time of flight. And it was repeated kind of for each different PDL strength, and it was done on a multi-site and multi-scanner approach. So in order to test an algorithm, there's different things you might want to think about. So these are some of the sort of things that you might want to consider. So then what did people think of those reasons? Obviously, I'm not there in the room, so I'll just assume some people are nodding, some people are shaking their head. But all those ones are actually written by ChatGPT. So it asked itself, how should we test the algorithm? So instead, with my more kind of clinical physics hat, what would I want before we start using these in clinical practice? And this would apply obviously to the algorithms you guys are developing too. So I think you want knowledge of how things develop, which you kind of mentioned, how they developed PDL originally. You also want to look at kind of phantom testing, lesion quantification, lesion detectability, image noise, any kind of over enhancement, robustness of the algorithm. You give it kind of some extreme inputs, and obviously to use it in clinic, you want it to be kind of FDA or CE marked device. So first of all, in terms of the kind of phantoms, actually the way the AI has kind of been trained, we probably can't really use phantoms in the classic way, because the likelihood is it's learned from human scans, so it's expecting a human scan like input to then enhance. So if you give it lots of phantoms, either the algorithm could learn purely on phantoms, but you're then going to get a biased answer. So one way around this is to do something called lesion insertion technique. So here you've got kind of synthetic lesion you can insert in the image, then you can kind of reconstruct the image as you normally would, and then you've got your kind of hybrid image with the lesion inserted. You can then know what the ground truth was of that lesion. So it's like a phantom, but with real clinical data. So when the AI algorithm looks at it, it sees a typical patient-looking cytogram. Also, there's nothing to stop you using phantom as well in the AI enhancement, and people can test that, but I think it's useful to do this lesion insertion as well. So this is what one of these cases looked like. So here we have the patient without the inserted lesion. Here you have the patient with the inserted lesion. The lesion insertion in this case is a 10 millimeter 4:1 contrast lesion in the head and neck area, so quite a small lesion. So see in the non-time flight image, can't see it too well, but it's much more conspicuous in the sort of AI enhanced version here and the ground truth one. So you can see it's kind of working as you might expect. So you can use this kind of lesion insertion technique to kind of assess the quantification accuracy in a new algorithm. So we did this for 32 different lesions, kind of from 10 and 50 millimeters in our PET data. And these are kind of some of the results we got out. So with the kind of map non-time flight image, we had for SUV mean a 50% accuracy and the SUV max just under 50%, and kind of acceptable level of noise. If we go to kind of the target image, or the time of flight map, we can see we go up to 6% SUV mean. So you can see it's kind of a 10% absolute increase on what we had for non-time flight, but crucially still not 100%. And this is an important thing that clinicians kind of, we have to always keep educating them, reminding them that the algorithms, whilst obviously PET image is great, you can do great things with them, great quantitative work, we're not getting exactly what's in that patient. There's always be a slight underestimate, especially for these small lesions. I think people sometimes think as you get the newer reconstructions, you do the Pearson modeling, you're getting almost perfect quantification, and you're really not. And I think as physicists and engineers, we guys will understand that, but I think there is some need to work kind of education to get, when the image is reported, ensure people understand exactly what quantitative value is in that data. And if we look at the AI algorithm, here you can see it's got up to 58% accuracy. So it's not exactly the same as the time of flight, but it's kind of got 80% of the way there of what that has got. So it's done the majority of the work with the time of flight in terms of SU mean, similar for SU max. And the noise is kind of acceptable level. It's kind of similar to what you'd get with the time of flight. So very slightly noisier than a non-time of flight image. So that's the lesion insertion. Now we look at lesion detectability. That's obviously a really crucial thing clinically to be sure and test out how that's working. So you can do model observer detectability. I'm sure there'll be talks at the conference about that. I think it's really important and should be done. However, I think to persuade people in the clinic to use these new algorithms, I think unfortunately there is always a need to have human scoring of these scans. So there's kind of confidence from radiologists of exactly what that image does, what it shows. So the way we tested this was we had 3 different radiologists blind score these images. So we gave them 50 different patients, quite a large number of patients, because each reconstruction had a non-time of flight scan, a time of flight scan, and 3 versions of the AI enhancement. So that's 250 PET scans they had to score, all with the corresponding CTs. So there's quite a lot to get ready and prepare on the different imaging workstations. But I think that sort of confidence from doing that amount of scoring is important to kind of help allow other centers to then take on and use that algorithm as approved. So these are the results on the lesion detectability. So you can see with a non-time flight map algorithm, we had good, so around about 3. They all scored on a Likert scale, non-diagnostic up to excellent, so nothing was scored non-diagnostic or poor, which is great. And you can see as you increase the strength of the PDL, so PDL low is pretty similar to Q-clear in terms of lesion detectability. As you increase the strength of the PDL, you're getting closer to the Q-clear time of flight that the system had trained on. So while the clinicians were scoring for lesion detectability, they also scored for diagnostic confidence and image noise as well at the same time as while you've got those up. And that's the same kind of metrics we've used for a variety of other kind of clinical implementation work, and it works quite nicely. So you can see here for the image noise metric, actually the lowest level of PDL enhancement, because it gives you the most kind of image smoothing, was given the highest score. Lesion detectability, as I kind of said earlier, this one, the PDL high, is given us the highest one. So again, significantly high. And then here we have for diagnostic confidence, which is pretty much a compromise between detectability and image noise, you've got the middle model. So depending on what you're kind of interested in would probably determine what sort of model strength you might do. But as I said at the start, for this particular algorithm, it's often dependent on what your input image is as to what's the best strength of PDL to use. But you can see, depending on what you kind of want to use, there's different strengths of PDL you want to use. But this gives us kind of confidence that the clinicians have got an algorithm. They've crucially looked at all the different variety of patient cases, and there were no kind of odd artifacts. They were happy with the images that they were given. So it gives us confidence in being able to use this algorithm clinically. So then looked at quantification as well in all these patients. So obviously lesion SU max, the lesions that were scored. So the highest level of the algorithm wasn't significantly different to the time flight scan. These ones are significantly lower, but you can see the kind of non-TOF is about 30% lower, similar to the lowest level of PDL. Medium is only -8%, and then this is kind of significantly similar. And then lung SUV mean, pretty similar for all the PDLs. And liver SUV mean, similar for the high PDL, and only very slightly different for the other levels of PDL. So in terms of like the clinical hat on for these sort of algorithms, so we know how it's developed. Rather than the phantom, we've gone for kind of lesion insertion technique, looked at lesion quantification, detectability, image noise. Another thing I didn't kind of show here for interest of time, but it's worth thinking about kind of the potential over-enhancement. So you want to be sure these algorithms don't over-enhance the images. So in this particular case, you kind of can know mathematically what the gain you'd expect from kind of going from non-time flight to time flight. So you can kind of, there's a sort of basically guardrails ensured that you don't go above that. You also want to ensure like the algorithm's robust. So we applied sort of extremes of beta, extremes of timing, so really short scans to kind of check that we're able to still get suitable data out. Obviously, for any sort of clinical product, you can't predict how people in the clinic are going to start using it. And the other aspect, obviously, you kind of want an FDA or CE marked device if you're going to start using it in a hospital setting. But I think these other settings before are really useful kind of to get things into the clinic and understand what the companies or you guys have done to develop this sort of work. So in this case, we're kind of happy with the testing, and then we're able to now use it for patients with better scans, and it's used routinely now on the latest scanner. So a variety of scanners are out there now. They're all being used with the AI, and it's great. You can see the improvement in image quality compared to the non-AI enhanced images. So I think there's an increasing use of PET as well as obviously other modalities too. And I think often clinical staff might be unsure how to test it. I think what they're kind of, I suppose, scared of in a way is it's presented as a black box. So you kind of have this magical algorithm that spits off these amazing images. You need to understand what that algorithm is doing in order to be able to have confidence and be able to use it in clinical practice. So these sorts of kind of tests that kind of mentioned for this algorithm, I think would really assist sites with clinical implementing any sort of algorithm as and when these things get developed. So going back to the kind of discussion between kind of map and no map and how the kind of challenges that it's used for. So obviously I mentioned the letters before about the lymphoma. So we were invited to write kind of one of these controversy articles for EGMI. So we were, us and other colleagues from other institutions, were kind of the for side of it. So kind of wanted to embrace and push the limits of new PET technologies. And there was a counterpoint article from other colleagues where they were kind of saying, actually, no, you need to think before we kind of implement these new technologies. And in terms of the, like I'd urge you, if you just read these two articles, to kind of see the two viewpoints. But in terms of the PET reconstruction, which is also what we're talking today, the principal argument was, and the kind of counterpoint argument is, if you're doing a clinical study, you need to have everything be consistently reconstructed to be able to compare data. And if you're trying to pool data and define thresholds at which you can determine a clinical response should happen this way or not happen this way, you want to have everything reconstructed in a kind of quantifiably consistent way, which obviously I'd agree with. There are ways of harmonizing data, but if you've got a MET, especially a live MET or something like that, where you can detect it early, that, in my view, is clearly better, and it's clearly in the patient's interest to detect those things early. Like, I think if it was your family member and they were scanning on a scanner and they'd basically degraded the image so it was applicable to the lowest kind of common denominator within a clinical trial, but actually you're missing something that the scanner could have picked up, and that's an issue. So I think there's a ways of where you can really kind of push technology, but also have able to take part in trials where there's kind of certain levels of harmonization to get the kind of different levels of data out to get the kind of trial data produced. But I think it is important to embrace technology and use the best possible reconstruction techniques that are available. So this is kind of a case in point to illustrate the need for this new technology. Really, this is a patient we had in Oxford. So above we've got the OSOM image. You can see just there a lesion in the breast. This is a female patient, 70-year-olds. This was an SU max of 1.8. And then with the MAP algorithm, you see quite striking how much better that lesion is there. So SU max of 5. And this particular patient, actually, after the PET scan, we then sent them for a triple assessment, so mammography, ultrasound, and breast examination. All 3 were negative. So the patient carried on, and then 3 months later, actually, this lesion had then become a small sub-centimeter ductal cell breast carcinoma, and it was then subsequently cured. So obviously, the patient had a good result from this. But actually, at this point, we've detected it early. So we've detected it before all the kind of routinely modalities did detect it. So it shows you that by embracing this technology, we can detect these things more easily. And this patient was lucky, obviously it was detected and was cured, and actually this was an incidental finding, but I think it shows you the need of these new algorithms, that everything's being developed. So in my view, also, we need to get these new reconstructions out into the clinic. I think it's important to get clinical staff to understand how these algorithms work, to understand the benefits of using them. I think what hasn't worked in the past is that algorithms presented, this is what you have to use, just use it. I think people in the clinics need to understand where the algorithms come from, what kind of the advantage of it, what are the disadvantages, where can it go wrong. I think that really helps with them implementing and using it and understanding its benefit. So the conclusion of this paper, which I think is still stand by really now, is kind of we look forward to all users embracing technology now and in the future for improved early diagnosis, and that's crucial, really, the early part, and detection, and crucially the benefit of patient care. So we all in it to kind of help patients. So if we can detect things early, that's clearly an advantage. So from your message kind of for you guys is please keep developing algorithms. It's really great to kind of see the improvements we can get in these sort of images and see what we can detect. So a variety of people took knowledge from kind of Oxford, GE, kind of Zurich and Cardiff did lots of image scanning, colleagues in Oxford, and part of the kind of AI work we did as part of this kind of national consortium of intelligent medical imaging, part of a Innovate grant given a few years ago. And also all different staff at GE that helped develop some of the algorithms we've presented now. So many thanks for listening. This is another example of a nice map case. Here you can see like there's a hot lesion here, and then when you apply map, you can see really much more clearly the small lesions near that. And this is a real PET scan, but I'm afraid not a map one, just a standard one, but had a very nice question mark in it. So many thanks for listening. Any questions?